Wound packing and cultures. The Agency for Healthcare Policy and Research panel developed clinical guidelines for pressure ulcer prevention. We need to look at the cost of pressure sores because they cost thousands of dollars per wound depending on the severity. There is a greater cost in client suffering, and we do increase the length of a hospital stay and or nursing care that's required to treat pressure ulcers. It's much easier to prevent ulcers than it is to treat them. Some prevention measures might be more expensive if you have a bed that's designed to prevent pressure ulcers or mattresses, and some all require a commitment to care, which would be keeping the skin free of contamination and relieving pressure through turning activities or placing devices, pressure relieving devices. Patients are at increased risk for pressure ulcer if they have impaired sensory input where they don't sense pressure or pain to move and decrease the pressure that's being put on a certain area of their body. If they have impaired motor function where they're unable to independently change position when pressure occurs. Alterations in level of consciousness where they don't sense the pressure or understand the need to move. Shearing forces that are caused by sliding or pulling a patient and exerting a force parallel to the skin. This breaks underlying capillaries. Friction is a mechanical force where the skin is dragged across a coarse surface and it affects the epidermis. It might be called sheet burn. Moisture reduces the skin's resistance to other physical factors such as pressure and or shearing, and it can soften the skin and weaken the tissues. This all contributes to providing favorable conditions for bacterial growth. Might be due to wound drainage or perspiration, urine, or feces. So we look at the different scales that are available for pressure ulcers. We have the risk assessment tool or the pressure ulcer prediction and prevention algorithm, the Norton scale, the Braden scale for predicting pressure score risk, and it assesses sensory, moisture, activity, mobility, nutrition, friction, and shear. We can't forget about, even though we don't have the actual assessment tool, we can't forget about bony prominences because they will not be able to tolerate pressure as well. If there is an extended amount of pressure or time, the tissue just does not tolerate it as well. And illness and age can also affect how well a patient tolerates pressure. So then we look at staging our pressure ulcers. We have stage 1, which is observable pressure that's related to alteration of intact skin. We may see a change in the skin temperature, consistency, sensation, or coloration. It would be persistent redness in light-skinned people and persistent red, blue, or purple colors in dark-skinned people. Stage 2, you have a partial thickness loss of the epidermis and dermis. It's superficial. It may look like an abrasion, a blister, or just a very shallow crater. Stage 3 would be a full thickness skin loss where there's damage or necrosis of the subcutaneous tissue, but does not go all the way through underlying fascia. It may look like a deeper crater. Stage 4 is a full thickness skin loss with extensive destruction. So you'll see some tissue necrosis, damage to muscle, bone, tendons, or joints, depending on the location. Now, staging classifies wounds. It does not describe the healing process of pressure ulcers. Now, when a pressure ulcer occurs, the physician may order irrigation of a wound, wound packing, and or cultures. When you irrigate, it may require to use personal protective equipment because of the risk of splashing. You use appropriate technique with sterile or clean solution depending on the type of the wound and the order. Use at least a 35 cc syringe. The diameter of a 19 gauge needle or an angiocath will deliver the appropriate pressure that's required to irrigate. Realize that if you have a deep wound, you may need to use a soft catheter for irrigation. Never occlude a wound opening or use excessive pressure that would damage the wound. When you're irrigating, the tip of the syringe or the angiocath should be approximately 1 inch above the wound itself. And always make sure that fluid flows from the wound outward. When you're documenting, don't forget to document the wound assessment, drainage, the irrigation solution that's used. How did the client tolerate the procedure? And if you applied a dressing, what supplies were used? And was it a sterile dressing or just a clean dressing? Now, a nurse can obtain a culture if an infection is suspected. You need to go by facility policy. But if the nurse obtains one without an order, she needs to confirm with the physician whether he wants this to be sent for lab results or not. Determine if the culture should be aerobic or anaerobic. Aerobic requires oxygen. The anaerobic requires no oxygen. You clean the area first with normal saline only. You don't want to use a substance that may alter the bacteria that's there. Use of other cleaning agencies affect the accuracy of the culture results. Make sure that you obtain the culture from new drainage. Apply pressure with a swab to cause tissue fluid to be expressed about the size of 1 centimeter and collect it onto the tip of the swab. That's for the aerobic culture. The anaerobic would be more for a deep wound cavity, and you obtain the culture from the wound following irrigation. Make sure that you wear clean gloves to remove the old dressing and to obtain the culture. Wear sterile gloves to clean and to apply the new dressing. Be sure you notify the lab if the client is on antibiotics because it can affect the results of the culture. If a culture and an antibiotic are ordered at the same time, always obtain the culture first unless there is some reason why obtaining the culture is delayed. And use 1 culturette per site. Return the swab to the tube and then crush the inner ampule if it has an ampule in it. Label the specimen with the date, time, the client's name, and the location of the culture. It really should be taken to the lab immediately. Wound packing. Well, purpose of wound packing is going to help debride a wound. Determine the physician order as to the solutions that the packing should be moistened with. Wet to dry dressing helps provide mechanical debridement of wounds. This is an example of packing a wound. You notice they're using a swab to help insert the packing into the wound itself. So how do we pack a wound? Well, first of all, you need to make sure your client is aware of what's going on, what this procedure is about, and make sure that they don't need any pain medication. If they need pain medication, administer it. Then you want to wait and give the medication the opportunity to take effect prior to doing the dressing change. Always assess the surface of the dressing for drainage and Keiko the drainage. Remove the packing with clean gloves. Inspect the packing and the wound bed for the presence or absence of drainage. Observe color, amount, odor, and consistency of the drainage. And then wash your hands before you do wound packing. Irrigate it if necessary or ordered. Obtain a culture if necessary. Measure the wound at least weekly. You measure wound depth, tunneling depth, direction of tunneling, uh, wound circumference, etc. You then set up your sterile field. Using sterile forceps or sterile cotton-tipped applicators, you gently insert sterile packing into the wound. Pack the wound loosely. Make sure you fill any dead space, undermining or tunneling. All wound surfaces should be in contact with the moist gauze. Packing should not touch peri-wound skin. In other words, the packing should not extend outside of the surface and touch the area around the wound. Cover the wound with dry sterile gauze and additional dressings as indicated. Secure it appropriately and document appropriately. Be careful not to pack the wound too tightly because it can actually block blood flow and delay healing. You pack only until the packing reaches the surface of the wound, never above the edges, because this can cause maceration of surrounding tissues. In other words, you soften that skin by keeping it wet. Fluffed gauze is often used to increase surface area in contact with the wound. Normal saline is usually the solution that is used to moisten the gauze, unless your physician orders something else. Cut any packing with sterile scissors if necessary, and allow just a small strip of packing to protrude from small and deep wounds to help facilitate removal. Again, just make sure it does not come in contact with the peri wound.